Hello, I'm Jeff Ibbott, and I'm an Associate Executive Director of the American Board of Radiology with the Medical Physics portfolio. We have prepared the video you're about to see to help familiarize you with the ABR's oral certifying exam and the remote platform. This video depicts the oral exam itself. There are a number of preparatory steps that you will learn about by completing your technical check, by reviewing the exam guide, and by attending our orientation webinars. Our video begins at the moment the candidate first meets the examiner and illustrates one of the 5 exam periods that make up a full oral exam. The video is based on an actual exam, but the roles of the examiner and the candidate are played by ABR volunteers whom you might recognize. The questions are actual oral exam questions that were used in a recent exam and have now been retired, so they are truly representative. And the actors portray the conversation that took place in an actual exam with a few edits to assure anonymity. As you will see, the exam is designed to promote a conversation between the candidate and the examiner. The examiner will ask the candidate to read the question out loud before starting to answer. This is to help the candidate focus on the topic, and so the examiner can confirm that the candidate has read the question correctly. During your exam, we encourage you to ask for clarification if you don't understand the question or have trouble seeing an image. And please ask the examiners to repeat themselves if you have trouble understanding them. You'll notice that the examiner's facial expressions and responses are quite impassive. They are trained not to indicate whether your answers are correct or incorrect, but they will say things like, okay, or that's fine, to indicate that they've heard and understand you, or perhaps that they're ready to move on to the next question. Please don't try to interpret anything they say or do as a hint to how well you're performing. I also want to explain that while an oral exam is necessarily somewhat subjective, we've done a number of things to make our assessment of your knowledge as objective as possible. First, the exam questions are written by experienced clinical medical physicists who are experts in the subject area. The questions are reviewed and edited by a committee of similar experts, and a guide to the examiner is prepared to clarify to the examiner what material is to be covered and where the examiner might focus the discussion. Sometimes follow-up questions are suggested, although examiners are permitted to ask their own follow-up questions. Next, shortly before the exam, the examiners meet to review the questions together, to agree on the approach they wish to take and the specific details they expect the candidate to know or not know. During the exam, you'll see that the examiner is apparently making notes to remind themselves about your responses. Try not to pay attention to this. The examiners meet many candidates during the day, and they use these notes to help with their recollections. They will also assign a score for your response to each question. The ABR uses a 5-point scale, with the midpoint of the scale being the lowest passing score. Each candidate is examined by 5 examiners, who each ask one question from each of the 5 categories of the exam. You can review this list of categories in the content guides on our webpage. The examiners ask the questions in a different order to make sure you're asked a question in each category by at least several examiners. Finally, the scores given by your examiners for each category are averaged. Again, this is done to keep the process as objective as possible. And it means that while you might struggle with the question from one examiner in a particular category, you might do much better with another examiner's question in that same category. In this way, it's possible to offset a low score with a higher score and still pass that category. In the video, after each question, you'll hear the examiner and me discuss the candidate's responses. And while we don't mention numeric scores, we use terms like high pass or just failing to suggest the scores that might have been assigned in an actual exam. We hope you find this video informative and helpful as you prepare to take your oral exam. All of the examiners you'll meet have been through the process as candidates themselves and are sympathetic to the stress you might be feeling. They want you to do well, and often their follow-up questions are intended to help you arrive at the answer. Be sure to engage with the examiners and stay focused on the questions. And again, we wish you success on your exam.
Okay, hello. My name is Matt Pogorsak. I'm going to be examining you in therapy medical physics. Before we get started, there are a couple of things I need to mention. First, may I see both sides of your whiteboard as well as your marker? Okay.
This is my marker.
Very good. Thank you. Second, and very important, during the exam, please don't hesitate to ask an examiner to repeat a question if you have trouble hearing or understanding us. All your examiners will be happy to repeat questions as needed. Okay, shall we go ahead and get started?
All right.
All right, you should see the first question on your screen.
I do.
Go ahead and read it, please. And you can either read all four parts at the same time, or you can read the first question, answer it, and then move on to the second. It's completely up to you.
Okay. All right. Okay, so what does it mean to calibrate a LINAC? Describe the basic calibration geometry and the equipment that is used to calibrate a LINAC. What component in the LINAC is associated with your adjustment, and where is it located in the LINAC? What happens if this device fails? So calibrating a LINAC is really the process of establishing a point somewhere in space where you know exactly where 1 centigrade is, and then you correlate this with what the LINAC reads. So the LINAC understands the monitor unit versus 1 centigrade. So you calibrate it such that 1 centigrade equals 1 monitor unit.
Okay.
So next is the basic calibration geometry. So there are really two parts to this. Both of these are described in TG51. So the first part is that you need to measure your beam qualifier and specifier, which for photons is the percentage deptus at 10 cm. So for that, you do need to use a water phantom or a water tank that's big enough. So you set the water tank up to surface at 100 centimeter, and then you put your chamber at 10 centimeter depth, and you measure your percentage deptus. So for this, you also need to use a scanning chamber, and you measure your PDD.
Okay.
Um, and then in addition to this, you also need a reference chamber to normalize your signal. So any signal fluctuation cancel out.
Okay, so we're talking about the basic calibration geometry. What does the setup look like? Overall setup. I know you mentioned the equipment and how to make a particular measurement, but how's the machine set up, the Linac that is,
Mhm.
relative to the water phantom?
So the gantry, you set this up to 0. The tank is directly underneath the gantry. And then you set your jaws to a 10 by 10 so that you have a 10 by 10 field at the surface of the water.
Okay, so where's the surface of the
Uh,
water
at
relative?
100 at 100 SSD.
Okay, is that the only way that you can calibrate a Linac, that is with 100 centimeter SSD?
Yeah, so the first part of measuring the PDD, that needs to be done at 100 SSD. That's what TG51 recommends. The second part where you actually calibrate your machine, so you select a point where you measure a centigrade and relate this to the monitor unit, that can be SSD or SSD setup.
Okay, so you mentioned a little bit ago about a calibration at a given point in space. What's different about that point if you're doing SSD setup versus, let's say, the alternative, which would be an SAD setup
Yeah.
technique?
So in my clinic, we use SSD setup. So what this is, you set your water tank to 100 SSD, and then you measure the dose at 100 SSD plus Dmax. So at that particular point in space, you measure 1 centigrade and you equate this then to 1 monitor unit. If you have an SAD setup, then you are calibrating at SAD. So your actual point in space is at 100 cm from the is at your ISO center, and that's what I think it is.
Okay, we're talking about calibrating a Linac. What component of the Linac is actually associated with this calibration process?
Okay, so when we talk about a monitor unit, we're talking about the charge that's measured in a monitor unit chamber. So we're really dealing with the monitor unit chamber. And that's in the head of the Linac. It's right under the flattening filter. And actually consists of 2 chambers that back each other up. So if one fails, the other one takes over. So when we do the calibration, really telling the monitor unit chamber how much charge to measure and what corresponds to 1 monitor unit, and then how that relates to 1 centigrade at our calibration point. And then, the basic task that this monitor chamber performs, it turns off the beam when that monitor unit reading is reached.
Okay, so tell me now, what happens if this device fails?
Yeah, so you're in trouble. You won't be able to count those because that's really the device that measures the charge and turns off the dose or turns off the beam. The other thing it does, it tracks flatness and symmetry. So that won't happen then. And I think if it fails, you get all kinds of interlocks.
Okay, so you've determined that this device has failed, and you need to do something in order to get the Linac back to being in operational state. So you replace this device, the monitor chamber. Tell me a little bit about the QA that you would do to make sure that you can then turn the Linac back to the therapist for patient treatment.
Yeah, so you essentially need to re-verify your calibration. So you can, recalibrate, verify everything is as you would expect it, or you can run some existing plans and measure the dose that they deliver and compare them with what you would expect. Or you can go in to service mode, you run 100 monitor units and make sure that the dose is equivalent to what you would expect from 100 monitor units.
Okay, is there
And
anything else that you would do?
yeah, because it also measures the flatness. So you could do something like throw in a profiler onto the machine and measure that the flatness and symmetry is still appropriate and hasn't changed due to the repair.
Okay, let's go on to the next question.
Very good. Well, that candidate seemed to perform very well on that question. I was impressed that very early on, even though this was a question about the geometry of calibration, she did mention TG51 and how important that was in the process.
Yeah, I agree. She definitely showed a good understanding of all issues related to beam calibration. She offered TG51 as the methodology, and very importantly, she was able to demonstrate that she has a good conceptual understanding that TG51 can be applied in two different geometries, either the SSD setup or the SAD setup. She really showed a good basis of knowledge as far as how TG51 can be applied.
Absolutely. And an interesting point about that, when she described the procedure at their institution, she mentioned that they calibrated 100 cm SSD and then mentioned Dmax. And at first blush, it sounded like she was saying they measured at 100 centimeters SSD plus Dmax. But I think she was again responding to the question, which talks about what is calibration, and was explaining that the dose that is measured is referred to Dmax. And so it's the dose at Dmax per monitor unit that is important.
Yeah, I agree. I agree with that statement. She focused very nicely on the intent of the question and didn't dive too deep into all the other related issues that go with TG51 correction factors, how those are measured, the fact, as you just mentioned, that the measurement of the actual dose is done at 10 centimeters. That was not the most germane aspect of this question that we were trying to have the candidates address. So she mentioned the calibration geometry. She mentioned the two different ways that TG51 can be applied. And very importantly, she also showed a good understanding of the monitor chamber. And again, she didn't go into too many details about how a monitor chamber works because that really wasn't the intent of this question. We didn't want to hear about how the chamber is constructed. We didn't want to hear about the different quadrants, but we did want to hear that the chamber is what actually turns the beam on and off in a linear accelerator and how important it is from that perspective. It was also nice that she mentioned that in addition to providing dose information, the monitor chamber also provides information about beam symmetry. So that's something that she offered on her own. It wasn't necessarily a part of the question, but it demonstrated a good knowledge of this particular aspect of the question.
It did, and also her understanding that should a chamber have to be replaced or adjustments be made if it's not functioning properly, that its performance not only in measuring output, but in verifying beam flatness and symmetry are very important.
Yes, precisely. So I think that the way that this candidate provided responses, I think that certainly we would classify this as a high pass on this particular
I
case.
agree. Yes, that she answered very well.
Okay, so for this question, you should see an image along with the actual question below. Do you see that on your screen?
Yes, I do.
Okay, great. So go ahead and read the question, please, and then let's talk about the answer.
Okay, so you're responsible for commissioning a C-arm LINAC-based stereotactic radiosurgery program in your clinic. Describe the required dosimetric data to be collected. Describe the data collection tools and measurement technique. describe the dosimetry commissioning and validation procedures. So when you talk about linear-based SRS and the dosimetry data, you really need to worry about small field dosimetry. So this includes the PDD, profiles, output factor. All of these need to be measured with at least 2 different devices. And each of these devices needs to be appropriate for small fields. So you want to use something like a diode, an edge detector, a diamond detector, or a micro ionization chamber. You also need to pay close attention to your MLC. So most likely you're going to have a high definition MLC, and you need to know things like dosimetric leaf gap, transmission penumbra, tongue and groove effect. So all of that needs to be well modeled in your treatment planning system. And the tools you measure for the PDD and profiles and output factor, it's really very much the same tools you would use to calibrate a LINAC. So you need a water tank, your ionization chambers, diodes, whatever measurement device you're using.
Okay, so we're talking about small fields. Can you tell me a little bit about how you consider or what you consider a small field to be?
Yeah, so in general, as a rule of thumb, anything that's 3 by 3 centimeters or less is considered a small field. But it really is a field where you're starting to use lateral scatter equilibrium, or where the source is obscured, or the size of your detector is approaching the size of your field. Any of these conditions make it a small field dosimetry.
Okay, previously you mentioned a few detectors. So tell me a little bit about some pluses and minuses to each of these detectors in the context of these small fields. And pick one, and then tell me a little bit about how they would work and how they're affected by the small field sizes.
Okay, so let me start with an micro ionization chamber. They're really small, so they may be subject to extra currents, for example, from the cable or the stem effect, and also prior irradiation. And they're very small. So the central electrode sometimes is made out of high-Z material, which means they can over-respond in your chamber. And that's something you need to be careful about.
Okay, let's now talk about some sort of a solid state type detector. Give me a comparison between what you just described for a microion chamber to how a solid state detector would function.
Yeah, so you mean something like an edge detector?
Yeah, that
Yeah.
sounds good.
So those are really good for small fields because their active volume is very small. I'm not really sure about their disadvantages. They're kind of the gold standard, and that's what I would use for small field dosimetry.
So let's say you're going to take measurements with both detectors, and you've got a very small field. So first you take a measurement with the microion chamber, and then you take one with the edge chamber subsequently. How would you compare the signals from each of those? Would they be almost the same? Would one be greater than the other?
Your diode is much more sensitive. It's a solid state, and it's gives you much more signal than the ion chamber. But there are also more dependencies with the diode. I think they are dependent on the SSD. They over-respond at low energies. There's also a temperature dependency. So you kind of have to take all of this into account when you're comparing those 2 detectors.
Okay, so let's now say that you finished the commissioning project for your radiosurgery planning system. You've set everything up and you're ready to start using this commission program with patients. However, you first want to validate the system. Tell me a little bit about your methodology or strategy that you would use for validation.
Yeah, so you definitely want to do some end-to-end tests in a phantom. You can use something like a Lucy phantom. So this phantom, you need to somehow measure point doses, so it needs to house point dosimeters as well as films. So I would start with some simple plans. You verify point dose, and you do a gamma analysis on the film, and then you can move on to more complex plans. And then really at the end, I would recommend an IROC verification. So they send out these phantoms that have OSLDs in them, and then you make a treatment plan to some specifications that IROC gives you, and then you send them back, and they then go and measure the point dose as well as the film dosimetry, and they send this back to you. So if you pass an IROC phantom, that really gives you a lot of confidence.
Okay, let's move on to question number 3.
I think this was another good performance from this candidate. She understood a great deal about the commissioning process for a stereotactic program and mentioned a number of key important aspects, starting with the dosimetry parameters, of course. But I was quite impressed that she went into some detail about understanding how important it is, rather, to understand the design of the MLC that would be used if one is being used, or perhaps cones for this kind of treatment.
I completely agree. She did very well on this question. Again, she started out with some of the basic physics that are associated with small fields. She was able to quantify what defines a small field, and she gave a little bit of, she showed a little bit of knowledge of what happens from a physics perspective with these small fields. And she talked about lateral equilibrium and loss thereof, and perhaps other issues that are related with measuring dose accurately for these small fields. She also then went further and was able to describe some of the detectors that are appropriate for small field dosimetry, and very nicely also described some of the issues that one needs to confirm when using these detectors, that one is actually getting appropriate signal that represents the true measurement of dose for these small fields.
That's right, and that was very important to explain that. I agree. I liked her explanation about some concerns with small volume ion chambers, how they can easily be affected by other influences, but also that diodes themselves are not immune from other influences, such as the energy and possibly temperature dependence.
Mhm. And then she very nicely closed out her discussion of commissioning such a program by talking about the importance of end-to-end testing, and talking about specific phantoms that can be used for those tests, and then ultimately mentioning that you want to do a formal independent end-to-end test using some sort of an IROC phantom and getting that independent verification of the program that has just been commissioned. So all in all, again, a very nice response to this particular case, and in my opinion, a high pass.
I agree completely. Yes, she answered completely and thoroughly, and there were no errors in her explanation.
So again, you should see an image followed by some text underneath. So
Mhm.
do you see the next question?
Yes, I do.
Okay, please go ahead and start reading the question. Take a
Okay.
moment to look at the image just to make sure that you're familiar with what's presented, and then go ahead and read the question.
Okay. So the physician orders image registration for the patient images provided above. What types of images are shown? Your registration software provides two options: mutual information or cross-correlation. Which one would you choose for this and why? Justify the type of transformation model, rigid or deformable. Which one would you use? how would you evaluate the resultant image registration?
Okay, so let's start with you telling
Mhm.
me what you see in these
Okay.
images.
All right. So the top row is a CT scan of a patient's abdomen, and the bottom is an MRI, abdominal MRI. So in this case, because I'm using two different modalities, I would use mutual information. A mutual information really looks for intensity, and it looks for certain patterns in the image. So it really works well when you need to register images from two different modalities. That doesn't work as well with correlation.
So why is that? Why isn't cross correlation as good?
Yeah, it has to normalize to itself.
So what's being correlated when we use a cross correlation technique? What are we comparing between the
Um,
two image sets?
uh, I'm really not sure.
Okay, okay, no worries. So kind of moving down to the next part, the rigid or deformable.
Okay, so looking at these, assuming they are from the same slice in the same patient, you can see that there are some differences in the liver and in the other areas. So in our clinic, we try to do a rigid transformation first, and if that doesn't look so good, we go to deformable image registration. I think in this case, deformable image registration would be good because you're in the abdomen and you see there can be a lot of motion and things can change.
Sure. So you mentioned motion and how things can change. How would you account for motion on images in terms of when you're putting together a treatment plan or anything related to the use of these images for planning purposes?
Okay, so for treatment planning, if you have something that moves, you want to have a 4D CT scan, or at least like a breath hold and a free breathing scan. And then you will look for the extent of motion. So you look at all these phases and you look for the extreme ends and then contour the tissue in all of those phases. And then you can make something that's called an average.
Okay, so for these two sets of images that you see in this particular display, these are static, right?
Okay.
So the CTs are, you mentioned, deformable to account for motion. How do you know out of all these options for motion that you're on the right phase or that you've deformed to the right anatomical location? In other words, how do you evaluate that if you're going to deform this, is this an area where we expect to see motion in accounting through the deformation process?
Yeah. Yeah, because you're near the lung and the diaphragm, you would expect that there's a lot of motion. So um, I guess when we've done this before in my clinic, we look at bony anatomy and compare soft tissue and see if it works well. And then it doesn't, I move to deformable image registration.
So in this particular case, we can kind of make out some anatomy on both images. And let's say, as an example, that the bony anatomy lines up really well, but your target does not, which does quite often happen when you've got significant breathing motion. So what's your approach then?
Okay. Um, so in any kind of image registration, I would really want to align the region that matters the most. So, for example, you want to look at the area that's of most concern, for example, the target. But also you want to look at the area that's around it, organs at risk, just anything that you definitely want to avoid, and things that may change a lot. So I will restrict the algorithm to that area. Is that what you're asking?
Yes, yes. Okay, let's
Okay.
go on to question number 4.
Your candidate didn't answer this question quite as well as she did the previous questions. She understood what registration was, why it was important in the clinic, but couldn't give us a good explanation about the process, about the important distinctions between rigid and deformable registration, and wasn't able to explain to you really what the two modalities that were mentioned were for deformable registration.
Yeah, I agree. She started out very well by describing the two image modalities that were displayed in the question. That was the easy part, of course. Then the meat of the question involved understanding and showing understanding of the different image registration techniques, mutual information versus cross correlation. She correctly identified when mutual information is appropriately used, but she had some difficulty describing the cross correlation technique, when it's best applied, how such a technique works. So that's really where she demonstrated some lack of knowledge that really then she did recover to a certain degree from that, because the examiner went and tried to guide her in the direction of providing a little more information about something that she knew about to a certain degree, which was deformable image registration, and how that works and how that's appropriate in the abdominal region, which is what we were looking at in this particular set of images here, and where the image registration was meant to be done. And finally, she did understand that when verifying whether an image registration, either deformable or not, is done correctly, that one needs to look at the images where the anatomy that is of most interest is meant to be aligned the best. So she did offer that as kind of a quality assurance process that one needs to follow when doing any kind of QA on an image registration.
I agree. That concept is very important, of course, in image registration, and understanding where we need to focus our efforts was important, and that compensated a bit for her stumbles earlier on in this question. So it seemed like she did adequately, but but it wasn't a stellar performance again.
I agree. I agree. There we go. So go ahead and take a moment to look at the two pictures that are shown there, and then go ahead and read the question, please.
Okay, identify and discuss the instruments in the figure. What diseases are treated with these applicators? Discuss the instrument and construction of the materials. What is their purpose? So these are applicators that are used for gynecological brachytherapy. You can see tandem and ovoids in both pictures. They're used to treat like gynecologic cancers, endometrial, vaginal, cervical cancers.
Okay, so you should be able to move your mouse. Yes, and I can see it on my side as well. So why don't you point to some of the different components that are included in this applicator set?
Okay, so I think this is the tandem here. It's used to treat the uterus, and they come in different sizes and lengths, also different angles. Uh, depending on what matches the patient's anatomy better. And I think these here are all ovoids. They're used to treat the vaginal cuff. So, at the edge of the vaginal area, I think these here, and this is all, they're about the same. This is all about the same here.
Okay, so tell me now a little bit about how these get placed into the patient. Which components, do any of these components that we're looking at here get attached together before they're put into a patient?
Yeah, um, so what I can tell you when I look at these images as a physicist, but really I've never actually seen a physician place these. Uh, the tandem goes inside the vagina and it goes into the uterus. Um, this part here, I think, is where the source dwells. And then I believe this piece here, I'm not sure, maybe this piece, but I can't really tell.
Hmm. Do you see my mouse as well?
Hmm.
Okay, so tell me a little bit about these components here and what their role is and how they actually complement these components.
Yeah, I think these are ovoids here. Um, that's what I'm trying to see. I think there must be pieces here that connect somehow to the tandem. But when I look at it in 3D, really in 3D, you can see the tandem and then you see the ovoids. But I'm really not so sure. I don't think I'm really doing this well. Uh, in 3D, I can tell what it is. And the ovoids just kind of go to the right and to the left of the tandem, which is in the center.
Okay, and finally, tell me a little bit about the material that these applicators are constructed with and why.
Yeah, so they are CT compatible because part of the treatment is that you first get a CT to verify the location of the applicators. So they can't be metal. So I'm guessing here it's some sort of plastic, but they need to be robust enough to be sterilized and reused again and again. Other than that, I'm not really sure what they're made out of.
Okay, let's go on to the last question here.
The candidate didn't do so well on this question, and she seemed to show a lack of familiarity with brachytherapy in general and these specific applicators in particular.
Yeah, that's correct. She did offer that she didn't have any direct experience with these kinds of brachytherapy applicators. She mentioned that she did participate in some treatment planning, but that she never was there when these applicators were being placed by a physician within a patient, nor did she give an indication that she was ever at the console when these treatments were being delivered. So I agree. This performance was not good. It She did show some knowledge of brachytherapy in general. She didn't mention high dose rate. I don't believe, although certainly that is the typical approach these days. She did mention that these are tandem and ovoid applicator sets, but she had difficulty really identifying the different components. She figured out where the tandem was in the applicator sets, but she had difficulty demonstrating where the ovoids were. Her mouse was sort of all over, and it wasn't really clear what she was pointing to when she was trying to identify the ovoids.
I agree. And at one point, I thought she was actually pointing to the vaginal cylinders and talking about ovoids. So you're right. She obviously hadn't had the experience of participating in these treatments. And of course, for a physicist to be familiar with brachytherapy treatments so they can provide the appropriate support and assistance is very important.
That's correct. This question was really aimed at ascertaining from the candidate that they have an understanding of how these applicators work, how they are put together, and how they relate to the anatomy within the patient. So she did correctly identify that the tandem is placed through the vagina into the uterus, but she never really got to describing where the ovoids are placed and what their role is. And because this question was geared mostly towards showing understanding of the applicator sets, this really was a failure on this particular case for the candidate.
I agree. I agree. It's important, as I said, that physicists be able to demonstrate their familiarity with not only the applicators, but the process of implanting and delivering a treatment.
Yes. So this time there are no images associated with this question. Please read the question and let's discuss the answer.
Okay, so the question is, discuss the quality assurance program you would establish to evaluate online adaptive radiation therapy plans before their delivery. So let me make sure I understand this. Are you thinking about something like an ethos machine or an MRI LINAC? The patient comes in, they get their imaging done, and then the physician wants to change the plan right there and then. How would you QA this? Is that your question?
Yes, exactly.
Okay. Yeah, so first problem is obviously your traditional QA doesn't work. Traditionally, you would run the test plan first, but in this case, your patient is here and is on the table. So the methods that I'm aware of is something like a Mobius plan, where you're doing log file based QA. So you deliver the plan and then measure like the plan delivery parameters. They go into the file and then you can go in and look at this file and make sure everything is okay.
Okay, so let's talk a little bit about log file analysis. And in this case here, what we're trying to do is perform some sort of quality assurance before the plan is delivered to the patient, right? So if you are contemplating the use of log files, that actually requires you to deliver the plan that you've generated and then do the analysis, the QA afterwards.
Yeah, that's right.
So, but in this case, what we need to do is do the QA before the patient is treated.
Yeah, so honestly, I'm not completely sure. This started in my clinic at the end of my residency. They were just installing an ethos then. I'm pretty sure the Mobius was used. There was some sort of QA platform. It didn't actually run the plan, but it like delivered the radiation and it did the mechanical delivery. Maybe I'm confusing something here.
Okay, so let's talk about that for a moment. So tell me some of the things that you would include as part of your protocol for checking a plan before a regular delivery. And let's say it's not an adaptive plan per se, but it's just more of the traditional. You've got time to do the QA before the patient comes for treatment
Yeah.
scenario.
Yeah. Okay. So then I do a very thorough physics check. And I first start with checking the documents. So in this particular case that you're showing, I'm not sure if that's necessary, if the patient is there, but anyway, that's what I would do.
Sure. Go on. Tell me a little more, please.
And then I go into the actual plan. I look at things like image registration. So that needs to be done in case of an online adaptive plan. And it would be very important because you need to register the image of the day to the original image. Then I would take a look at the contours. So I would verify whether, who made these contours, physician or therapist. So I would like to look at these adaptive contours. I would look at those, and then I would also check field parameters, make sure those are accurate. I look at the MLC motion, just to see if everything looks all right. I'd look at this in the beam's eye view. I would evaluate the DVH, make sure all the constraints that the physician has set are met. And then I look at the dose distribution. Everybody does the order a little bit different, but this is what I would do.
Okay, so you've given me a description of your plan checking protocol. So now what we want to do is take it to the next step and gain some sort of confidence that the dose that this plan is predicting and has been approved for this patient is actually going to be delivered to the patient. So tell me a little bit about any QA program that you've worked with that would satisfy that aspect of
Yeah.
pre-treatment quality assurance.
Yeah. So part of the pre-treatment QA is the use of a secondary calculation program. So you recalculate the dose using the parameters from the treatment plan, but using a completely different independent system. So that would be another level of assurance that what you planned is what you actually deliver.
Okay, so let's now jump back into our adaptive radiation therapy scenario that this question is based on. And could what you just described, the secondary calculation, MU calculation, is that something that could be used in the adaptive radiation therapy process?
Sure. If it's robust enough, then yeah, why not?
So what would lead to it being not robust enough?
Yeah. So for online adaptive, most likely you're looking at the VMAT or an IMRT plan. So your secondary calculation program uh, would not have, can't be just like a simple hand calc. So you would need to be something more robust, something that's takes more into account.
So let's now say that you've done the QA that you have as part of your protocol for the adaptive process, and let's say that you find something out of the ordinary or something that suggests that there might be an inconsistency or a problem with how the LINAC is set up for treatment. What would your approach be in this case if you have a suspicion that something isn't just right?
Yeah. So in a case like this, uh, especially if the patient is already there, I would always go back to the physician and have a discussion and show the physician what I found and open up this conversation and this dialogue. So, in terms of plan quality, for example, there may be a reason why we are accepting lower coverage or higher dose to an OER on that particular day. So, and from there, I just feel like it's a discussion between me and the physician. And then it's a clinical decision that really the physician needs to weigh in and use their clinical judgment and decide if this is okay or not.
Okay, well, we've reached the end of our time together. That's the last question for this session. Real quick, would you please show me your whiteboard again, the front and the back?
Front, back.
Okay, wonderful. Well, I wish you all the best in the remainder of your exam.
All
Have a
right.
nice afternoon.
Thank you.
Bye.
Bye.
In this case, the candidate started off seeming to be rather confused about the issue that the question was asking about. And of course, she did explain that she didn't have direct experience with adaptive treatment, although she did mention a couple of delivery devices that would be relevant for this situation. And of course, we're talking about online adaptive treatment here, which is a very important distinction. But she did manage to get through some of the important concepts, I thought.
Yes. I agree. She did have a sense of what the correct approach would be to doing QA, but she really stumbled a little bit in that she never got to the point of, at least initially anyway, describing that you've got the patient on the table and you need to do something from a QA perspective that would perhaps involve not necessarily running the beam in the traditional way as you do for non-adaptive delivery of radiation therapy. You have time to do the QA. The patient isn't on the table, of course. So the examiner felt that perhaps it would be helpful if she was asked about the more traditional QA approach, where you have the time to expose, let's say, an ArcCheck device or some other QA tool to evaluate the beam that is about to be delivered to a patient, perhaps the next day, and then she demonstrated that she was able to work her way through that, showing that she has a good understanding of plan checking protocols and things that relate to good QA as far as plan checking goes. And then the examiner tried to bring her back to the question that was being asked in this case. How do you apply what you just described to the scenario where you've got the patient that is on the table and that you need to do something with, perhaps before you are able to actually QA the plan from a plan delivery perspective? So I agree, this wasn't a stellar performance. She did demonstrate enough knowledge of the process, I think, that she would gain a pass in this category. There was one other issue at the end, and perhaps you can mention that as well. That was somewhat concerning.
Right. I felt that she was too willing to defer to the physician's judgment as to whether the QA results were acceptable or not. And of course, we all understand that the physician is responsible for the patient and does make the ultimate decision. But it felt to me that she wasn't prepared to defend her measurements and perhaps argue a little bit more for the, the the results and the decision that the QA measurements were leaning towards, and that rather she would just present this and then allow the physician to make his or her own decision. I was a bit concerned about that, but I agree, given that this is a very new technology and a lot of people haven't been able to get the amount of experience that we have with more conventional techniques. We still expect people to understand these techniques and principles like QA. But given all that, I agree with you that this was a passing response.